So hello everyone, and thank you so much for the invitation. I'm going to be talking today about advancements in TB diagnostics and diagnostic biomarkers. And another title for this could easily have been, How Can We Predict the Future? So why do we need better TB prediction? The progress on the global scale towards the WHO targets of the NTB strategy has been suboptimal. We will not get there by just employing what we already have in terms of tools and support, and we need something transformative. A vaccine that would prevent TB disease in adolescents and adults would be transformative, but we do not have that yet. Large-scale preventive treatment might be an effective alternative. We know based on mathematical modeling of 11 different transmission models used to predict the percentage reduction in TB incidence over a 10-year period in India, China, and South Africa, that the greatest reduction occurred with a combined approach with active case finding and preventive treatment interventions. There was a 75% reduction in these countries. Unfortunately, the existing LTBI tests that we have a low positive predictive value. So currently with our LTBI tests, the number needed to treat is 20 to 50 in order to prevent one case of TB disease. Can we reduce the number needed to treat so that instead of treating all patients with LTBI, we only treat those who are at highest risk of progressing to active TB? So how can we improve TB prediction using our existing tools? We could use risk profiling without using LTBI testing altogether. And it's important to at least think about this because there is a high cost associated with IGRAs, and the TSTs do have their logistical challenges. So a TB disease prediction rule was used in a study in Peru based on host and household factors. However, the problem with these kind of rules is that they need to be derived and validated in the population in which they will be applied, and this limits wide-scale application. Another way in which TB prediction could be improved with our existing tools is risk profiling with quantitative LTBI testing. Rishi Gupta et al. At University College London studied 10,000 individuals who had QFTs, T-spots, and TSTs performed. He found that the TB incidence clearly increased with the higher test results. However, even for the highest quantitative results, the number needed to treat was still 20, which is a positive predictive value of 5% at best. So therefore, including quantitative readouts of IGRAs and TSTs in prediction rules does improve the TB prediction, but only to a limited extent, about twofold. So that leads me to the spectrum of tuberculosis. We now know that TB is not just black and white, not latent TB and active TB, but there's a range of pathology which exists between the two ends of the spectrum. Studies have been conducted and found that inflammatory pathology was already present 6 to 12 months prior to active TB. This brought the concept of incipient TB, which is a state of pathology of varying duration that is different from latent infection, but it exists before clinical disease develops. There is possibly also an intermittent stage of subclinical TB, which is either asymptomatic or oligosymptomatic. These terms have been used in different ways in different studies, which adds to some of the confusion. We know that individuals can move between stages, and this is a highly dynamic process. So somebody who has incipient TB could actually go back into latent TB and vice versa. As we already know, individuals can go from latent TB to incipient TB. it would be best to have a test which could detect incipient TB so that subclinical and active TB can be prevented. So how does incipient TB differ from latent TB? So although both latent TB and incipient TB will be, in most cases, radiographically normal, they will be asymptomatic, and cultures will also be negative. We know that individuals who have incipient TB have inflammation going on, more so than with latent TB. And as you can see in this study, it was found that PET-CT scans will actually light up in patients who have incipient TB as opposed to those who have latent TB. And therefore, PET-CT scanning may reflect an early event in TB reactivation, and this could be of value in biomarker development. So we actually have had a surge of TB biomarker research over the last 10 years, and this has been due to two developments: the availability of large cohorts in which exposed individuals were followed up for the development of TB, and the specimens were biobanked. And also due to technological advances in biomarker discovery, in particularly transcriptomics with the advent of RNA signatures and PET-CT scanning, as we discussed in the prior slide. These biomarkers have four potential uses. They could be useful in diagnosis and triaging, in monitoring TB treatment, as correlates of vaccine protection, and particularly for this talk, for the prediction of TB disease / diagnosis of incipient TB. Research was especially pushed after publication in 2017 of a WHO target product profile for framework for evaluation for a test of TB prediction. This test had to perform better than an IGRA, had to be easier to perform, and less expensive, and this is a high bar to jump. Various host biomarkers have actually been tested over the last several years for TB prediction, including T-cell activation differentiation markers, blood cell counts, immunoactive proteins, gene expression profiles, and small circulating molecules. So what was, in conclusion, the performance of these biomarkers? We know that various inflammatory markers predict the occurrence of clinical TB over a period of up to 12 months. These biomarkers have a moderate predictive value. They actually did not meet what was the minimum WHO target product profile criteria. The prediction is best in the 3 to 6 months before TB disease occurs. It was also found that selected RNA signatures seem to perform more or less similar, with a maximum positive predictive value of 10 to 15% over a period of 3 months. We also know that single markers may perform as well as RNA signatures, but further evaluation and head-to-head comparison is needed. Unfortunately, in the only study which has been published so far and was actually recently published is the Cortis Trial, in which these biomarkers were put to the test. Unfortunately, in this study, biomarker-based preventive treatment was shown to not prevent TB disease over the 15-month period. So where does this lead us to? More questions, which is not a bad thing. So, how can we use these incipient TB tests in a more productive manner? Right? Is our time point of testing where it should be? How do we treat when a test is positive for incipient TB? Should we treat this as if it was a case of LTBI or a case of TB disease? Secondly, how do we achieve cost effectiveness? We know that tests which are based on RNA signatures will probably not be cost effective. Thirdly, how can we do better in preventing TB disease progression? All the tests so far have a positive predictive value of a maximum of 10 to 15%, which is still a number needed to treat of 10. And this may just be coincidence, or it may simply mean that we can only predict the future to a certain extent. So that brings me to George Comstock, who is an excellent public health physician, epidemiologist, and educator, and he described in his paper the analogy of TB to the two-hit theory of cancer pathology. He stated that the TB bacillus is the initiating cause, but some reduction in the body's immunity is the promoting cause of TB disease. Both factors are required for the occurrence of TB disease. But what is the factor or the factors that define the tipping point of going from LTBI to further along the spectrum to TB disease? And it's only once we find out what these factors are that we are actually going to be able to prevent TB disease from occurring. And I hope in the next 5 to 10 years, somebody will be standing here and letting us know what these factors are. So thank you for your attention.